So my name is Jacob Wallace, health economist by training, assistant professor at the Yale School of Public Health. In a past life, I worked as a policy analyst for the Department of Health in New York State. And while I was there, was primarily focused on issues related to Medicaid policy and the Medicaid program there. And so the 3-ish years I spent there over a decade ago now, are what sparked my long-term interest in the challenges and opportunities associated with the Medicaid program. So the Medicaid program, just by way of background, accounts for about 28% of state budgets, covers about 77 million people, and represents 16% of US healthcare spending. And most probably relevant to my research interests and what we talk about today, about 70% of the enrollees in the Medicaid program are in managed care plans operated by private firms. And my current interest at the moment and the focus of my research has been to try and understand how states should regulate and manage competition between those private firms in ways that constrain costs while at the same time working to improve the health and satisfaction of Medicaid employees.
Perfect. So what's the sort of core area that you're focused on with Chima and Dumile in your brief?
Yeah, so Chima and I have become very interested in Medicaid auto assignment. And so by this, I mean that in Medicaid managed care, states have mandated that enrollees receive their benefits through private plans. What that means is they need a mechanism to assign folks to a plan if they don't make an active choice. And so in most states, there's a designated choice period that runs from say 60 to 90 days. And if enrollees have failed to make a choice within that period, this is when auto assignment is triggered. Auto assignment is the process by which a state will select your plan for you, place you in that plan, notify you you've been assigned via email or letter, and give you an opportunity to opt out. But in practice, there's a lot of inertia in these auto assignments, perhaps not surprising. And 80 to 90% of folks do end up staying with the plan that states assign them to. This, of course, means that this is a very, very powerful tool. And you might be inclined to think that this is a high stakes decision. Most people will obviously pick a plan. And so this is a tiny fraction of Medicaid population, but that unfortunately is not the case. Based on some survey work by Kaiser Family Foundation, we've calculated that about 45% of Medicaid enrollees nationally are auto assigned rather than choosing their plan. If you're thinking to, a model of managed competition whereby, recipients or Medicaid enrollees would vote with their feet for high quality plans, plans that serve them, and by doing so, discipline those plans and encourage competition on things that matter to enrollees, it's, disturbing to say the least that only about half of enrollees are making an active choice. And just to put kind of a number on this, if those auto assignment rates remain stable over the next decade, that would mean about 25 million Medicaid enrollees would be auto assigned, say, in the next 10 years. And so this is a high stakes problem from our perspective, because there's a growing body of literature suggesting that the health plan you're assigned to or enrolled in really does matter. It matters in terms of costs to the program. So programmatic costs in the Medicaid program. It matters for your satisfaction, and it can matter for your health as well. And so just to give a couple, quick examples, there's some recent work by a colleague, Jason Abeluk, and co-authors suggesting that the health plan you're in can actually affect the likelihood that you survive in Medicare Advantage. I have some work in New York State Medicaid suggesting that, the lowest cost plan in a market might be about 30% lower spending than the highest cost plan in a market. Those are very substantial savings. And we're talking about really only the set of things a health plan would do. In the Medicaid program, there's no cost sharing. And so the patients in that low spending plan are not facing higher financial risk. This is purely on the basis of what those plans are doing. And so, put these two pieces together. Half of Medicaid enrollees aren't making an active plan choice, and plans matter a lot. So our view is that this is an opportunity for a very large scale nudge that states can use to improve the matching between enrollees and plans in pursuit of programmatic goals. And to put an even finer kind of tune on, this is a complicated problem. And so I think one that we approach with humility and I think would require a partnership, a broader partnership than we usually see between states, researchers, industry, to sort of build on this opportunity and leverage this large scale nudge to improve matching.
And so what, I think your core goal is really to improve this match. What are you sort of recommending is tangible steps states could take now, or how should they be thinking about the savings on offer and how to get to it?
Great question. So this was my personal journey through my dissertation to sort of try and study and answer this question. I think of it as sort of a two-step process. The first step is to better understand what the plans in your market are offering. And to better understand what the plans in your market are offering, you have to really measure kind of causal differences in spending and satisfaction across those plans. And by causal, I mean, we worry when we look at observational data of differences in spending across plans in a market that some of what's going on is differences in the things those plans actually do to, say, constrain costs, the way they manage care. And some of it may be due to the sorting of different types of enrollees into different types of plans. And so auto assignment, while I've been mostly discussing it as a lever or a tool, it is also an opportunity to better understand the plans in states' markets. And so the first step of the two-step process is to try and leverage the auto assignee population, where the decision mechanism is outside of the hands of the enrollees and actually in the state's hands, to better understand kind of causal differences in performance across the plans in your state. And that's work I've done in New York that suggested large differences in spending, as well as in the satisfaction of enrollees. Step two is to sort of pin down the particular features of plans that really drive those differences. And so the feature I have focused on so far in my work is the provider network of those plans. And it turns out that there are kind of opportunities to improve the trade-offs that we're getting out of this market by, for example, nudging enrollees towards narrower network plans, which would constrain their spending, while ensuring that those narrower network plans have their particular providers in network. And so at the time of assignment right now, states that assign at random, for example, don't account for whether your provider is in the assigned plan. That creates disruptions unnecessarily and leads a lot of those enrollees to end up switching plans, which is a further disruption. And so what we've identified is an opportunity here to reduce spending by nudging folks towards sort of narrower networks that will constrain maybe perhaps more of the low value utilization, but preserve satisfaction and more of the utilization of high value care by ensuring continuity. And so if you're a state, what you need to know at the time of assignment is what was the prior utilization of an enrollee. That's typically observable in your fee-for-service data, or perhaps data on a prior enrollment spell. And you need to have measures of the causal differences in performance across plans in your market. And if you put those pieces together, you can construct an allocation of enrollees that we project would be able to reduce spending, at least in the population we've studied, by about 2% without harming satisfaction or reducing the use of high value services.
So you're really saying, look, there's just this very big opportunity for us to do better, and it's sort of working together to capture the savings and improve the experiences of policyholders.
Exactly.
So, can you give us a sense of the potential savings that are on offer, or a sense of a lower bound of the savings?
Sure. Yeah. And I think the 45% of kind of national Medicaid population being auto-assigned was at least an eye-popping number for me. The state that some of my work was based in, New York, actually has a lower auto-assignment rate on the 5 to 10% level. But if you scale up these 2% savings, and in some ways we believe those to be sort of a conservative estimate, but if you scale up these 2% savings, that translates to approximately a 1% reduction in sort of national Medicaid spending. Were you to assume that kind of going forward, all new auto assignments nationally would be done via smart default. Obviously, it will take a little time because there's a stock of 70 to 80 million Medicaid enrollees, and we're only auto assigning, 25 million new enrollees over a decade. So this is a process, but if we flip that switch, if we work with states to adopt smarter defaults, over time, we believe this can generate about a 1% saving to national Medicaid spending And given that Medicaid is a sizable fraction of overall spending, we think this translates to approximately 3.7 to 9.2 billion in annual savings, or about a 0.25% reduction in national health expenditures on the kind of high end of our estimates.